All right, I think I'll go ahead and get us started. Welcome to our annual Fall Implementation Science Seminar Series. My name is Dr. Alethea DeRogers. I'm an associate professor in the Department of Psychiatry and Human Behavior at Brown University, and I'll be hosting the Fall Seminar Series. This is the 8th year of our Bridge Program's Implementation Science programming, and we are thrilled to bring these seminars to our Providence and Rhode Island community of implementation scientists, as well as those of you who are joining us from other regions. We are also grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or Advanced CTR, for supporting the technology, logistics, and marketing of these seminars. And we recognize our partnership with the Brown Alcohol Research Center on HIV for their support. Now it's my pleasure to introduce our speaker for today, Dr. Sophia Bartels. Dr. Bartels is a postdoctoral fellow at the Center for Health Optimization and Implementation Research at the U.S. Department of Veterans Affairs. Dr. Bartels has over 8 years of experience evaluating the implementation of evidence-based mental health, substance use disorder, and HIV interventions, and testing strategies to scale them up in healthcare settings both domestically and internationally. Her work includes using mixed methods to assess sustainment of evidence-based interventions and to test the effectiveness of novel implementation strategies, with a focus on improving outcomes for individuals experiencing or at risk of homelessness. The title of her presentation today is Optimizing the Development and Tracking of Implementation and Sustainment Strategies. Lessons learned from 2 large-scale implementation science studies. As a reminder, you can put your questions in the chat function throughout the seminar, and we will save time for Q&A and discussion at the end of the time today. So thank you so much again, Dr. Bartels. I will turn it over to you.
Excellent. Well, thank you so much for having me here today, and welcome everyone on this snowy, at least in Boston, Tuesday. So I'm going to go ahead and get started. So just my disclaimer and funding, the views expressed in this presentation are mine alone and do not necessarily reflect the position or policy of the Department of Veterans Affairs or the United States government. And then the work that I'm presenting today was funded by the following grants that you can see on the screen. And so before getting really into the presentation, I just want to acknowledge all of the incredible researchers and research staff that made this work possible. On the screen here, you can see the UNC Project Vietnam team. And I want to highlight both the SNAP research team and the eBay research team who made this work possible, in addition to Dr. Vivian Go and Dr. Mel Miller, who are the co-PIs on the projects that I'm going to be talking about today. So today I'm going to give some background, talk about 3 different types of implementation methods, implementation mapping, and I'm going to focus on 2 different studies. You can see here kind of in parentheses. So I'm going to talk about the eBay study. Then I'm going to go into the second method, implementation strategy tracking, and talk about the SNAP study. And then I'm going to finish by talking about sustainment strategy development and talk about both the SNAP and the eBay study. And then I'm going to end.
Excuse me, Sophia. You have an inclement winter weather alert on your screen.
All right, let me just acknowledge that and escape from my slides really quick. Okay, wasn't sure if everyone could see that. I was hoping not. All right, so let me just go back. Okay. All right, is that looking better?
Yep, and then you just have to remove the app that's zoomed in. Yep, there you go.
Well, thank you so much, everyone. That's a symptom of being in this Boston winter storm. So as I was saying, I'm going to end the presentation by talking about a little bit about some of my current work and some key takeaways. So starting with some background, while topically my research interests really sit at the intersection of mental health, substance use disorders, and HIV treatment and prevention research, my research interests are really motivated by these 2 quotes. So first, bridging the no-do gap has been called one of the most important challenges for public health in this century. And intervention sustainability has been defined as the most significant translational research problem of our time. And some of the best tools that we have to address these challenges come from the field of implementation science and include implementation and sustainment strategies, which are defined as the methods or techniques used to enhance the adoption, implementation, and sustainability of clinical practices or programs. However, while the concepts for these strategies have been around for a while, although maybe a little less time for sustainment strategies, more research is really needed in how to best optimize them, particularly ways that are rooted in partner engagement. So today, I'm going to be talking about 3 different partner engaged activities that we used with our Project Vietnam collaborators for optimizing the development and tracking of implementation and sustainment strategies as part of 2 large-scale implementation science studies in Vietnam. So jumping right into the first method, I'm going to be talking today about implementation mapping with a focus on this first study, the EBI study, which I'm going to explain in just a minute. So implementation mapping is a systematic process that was developed by Fernandez et al., and you can see the citation at the bottom of the screen. And it was developed for planning or selecting implementation strategies, and it was originally grounded in intervention mapping. And implementation mapping can kind of help overcome the tendency to select strategies that maybe we're most familiar or comfortable with, but they don't actually necessarily address the key implementation determinants. And because of that, they're not going to lead to our target implementation goals, or we're picking strategies that really aren't grounded in strong theory and evidence. And so implementation mapping includes 5 key tasks. So the first task is conducting a needs and assets assessment and identifying kind of our adopters and implementers. So when you're thinking about adopters and implementers, this is who's going to decide to use the program, who's going to implement the program, and who's going to make sure that the program is sustained over time. After conducting this needs and assets assessment, the next step is to identify our adoption and our implementation outcomes, so things like fidelity, penetration, all those good outcomes. And then next, coming up with our performance objectives. And so the performance objectives are really asking what needs to happen in order to achieve our implementation outcomes, who needs to do what, and why or why not would they do it. And so this why or why not would they do it gets into identifying our implementation determinants, so our barriers or facilitators of implementation. And once we have our outcomes, our objectives, and our determinants, we can then create these so-called matrices of change where we're really mapping these the outcomes to the objectives to the determinants, so we can really systematically kind of connect these 3 different pieces. And once we have that, we can then select our implementation strategies. So first, we're going to think about kind of our theoretical kind of behavior, the things that would need to happen, our kind of behavior change techniques that would need to happen in order to overcome some of our barriers to implementation. And based on that, we can then select our implementation strategies. And then that gets mapped on to our matrices of change. So we've got kind of our outcomes, what we're trying to achieve, what do we need to do to get there, what might be some barriers to getting there, and then what are the strategies that we might be able to do to overcome those barriers. So that's step 3. Once we do that, we can then create our implementation protocols for actually carrying out our study and our strategies. And then we're going to want to evaluate our strategies to see if they actually are able to improve our implementation outcomes. So we used implementation mapping within the context of a study in Vietnam, whose goal was to test an innovative implementation strategy that's grounded in experiential learning theory. And I'll talk about what that is in a minute. And the goal of this study was to scale up an evidence-based brief alcohol intervention across 30 HIV treatment clinics in Vietnam. And we call this study the EBI study. And so, as you can see, this is a pretty large-scale trial, 30 clinics. And so providing a little bit more information about our implementation strategy, we learned from formative research that we actually conducted at the end of the effectiveness trial for this brief alcohol intervention called the REDART study. When we decided to interview clinicians as we were thinking about scaling up this effective intervention more broadly, and we wanted to talk to them about what might be some barriers from their perspective about scaling it up. And what we learned from them, and we kind of heard a little bit throughout the trial, was that in Vietnam, like in many other places, alcohol use is extremely normative. And providers expressed some hesitation around counseling patients around alcohol use when the providers themselves had, in some cases, pretty high levels of alcohol use and didn't necessarily see some of the downsides of drinking. And so because of this, we decided that we wanted to come up with this experiential brief alcohol intervention where the strategy was that in our intervention arm, before the staff delivered the brief alcohol intervention to patients, they would go through this intervention themselves, both to potentially address some of their attitudes or behaviors around alcohol use, and also to kind of give them a little bit more comfort and experience in using these motivational interviewing and counseling techniques because they hadn't really done much of that before. And so that was what we did in our intervention arm, this experiential brief alcohol intervention. On the other side, in our control arm, we decided to use implementation mapping to develop control arm strategies. And we wanted to do this because we know that to get an intervention up and running, you can't kind of just train and pray, kind of train people and let the intervention happen. You do need to think about some challenges that might get in the way and you might need to overcome before implementation. And so we conducted an implementation mapping activity to come up with some barriers to implementation and identify some strategies that we were going to apply in both our intervention and control arms. So thinking about things, some barriers like leadership buy-in, workload challenges, all of those types of things that we know need to be overcome as kind of a baseline in order to get an implementation, in order to get a new intervention up and running. So this was kind of like our standard of care. So our study team worked with our local collaborators to conduct implementation mapping, kind of aligned with those 5 steps. So the first thing we did is that we identified the adopters and implementers of our brief alcohol intervention. And so this included the VAC, which is the Vietnam Authority of HIV/AIDS Control, which kind of used to be the government body responsible for HIV prevention and treatment within Vietnam. We also included provincial Centers for Disease Control, HIV clinic directors, our HIV clinic counselors and staff, and then kind of our facilitators and the central team. So we identified our adopters in the first step, and then in the next step, working with them, we were able to state our implementation outcomes. So these included things like fidelity to the brief alcohol intervention, penetration, acceptability, and costs. And then we also listed our effectiveness outcomes. So these were things like viral suppression, so kind of how suppressed people's HIV are, and then also alcohol outcomes, so things like PEth and Audit C. And then having come up with the outcomes, our implementation and effectiveness outcomes that we were trying to achieve through our brief alcohol intervention and our implementation strategies, we then came up with our performance objectives. So thinking about who in this intervention would need to do what in order to implement and sustain the brief alcohol intervention. So this has all been a little abstract. So I'm going to give you a more concrete example of this implementation mapping matrix. So here you can see 2 different examples of kind of rows in our mapping matrix. So these are listed by the actors, and the actors are the people who are actually going to carry out our implementation strategies. So one of our outcomes was that we wanted clinic counselors to implement the brief alcohol intervention with fidelity. And in order to do that, one of the things we knew they would need to do was that counselors would need to systematically screen all ART clients for hazardous alcohol use. And then kind of at another level, we knew that another actor would be the national VAC leaders. And one of our outcomes was that we wanted the provincial CDCs and clinic leadership to support and find implementation of our brief alcohol intervention acceptable as another one of our implementation outcomes. And in order to do that, we knew from talking to the VAC, particularly given that in Vietnam, a lot of policymaking is really top down. And so we knew that kind of these national leaders would have to demonstrate that the brief alcohol intervention was important and a priority to both the CDC and the sites in order for them to kind of find this intervention acceptable and appropriate. So having described kind of the adopters, the implementers, and the outcomes, the next step was to identify determinants, so our barriers and facilitators to implementation. And we were able to do this through kind of the initial needs assessment that we conducted through kind of formative interviews that took place before the intervention, and also discussions with the VAC collaborators at Hanoi Medical University, which was kind of our local academic partners, and the provincial CDCs and study staff. So here we're adding a new column to our matrix, which is our determinants. So if we've got kind of one of our objectives being that we want counselors to screen all ART clients for hazardous alcohol use, talking to clinic staff, we knew a few determinants would be motivation to screen all patients, and then potentially forgetting to screen all patients. So those were things we knew we would need to address in both our standard and our kind of our control group and our intervention group in order to get this intervention up and running. And then at kind of the next level, as another example from the VAC side, in order to have the VAC demonstrate importance and priority of scaling up the brief alcohol intervention to CDCs and sites, some determinants might be relative priority of the BAI for the sites, which could be a facilitator, and then also how aligned the brief alcohol intervention is with national priorities. So these are a few examples from our implementation mapping matrix. And then finally, having identified our outcomes, our objectives, and our determinants, we then came up with our implementation strategies by actor that could potentially help to address some of the determinants that we came up with in order to achieve our performance objectives. And so we did this kind of using the ERIC taxonomy of the 73 implementation strategies and brainstorming with our partners. And so here you can see, for going back to the matrix, for the determinants of motivation to screen all patients and potentially forgetting to screen all patients, we kind of dove into some theories around implementation climate and how do you create a strong implementation climate. And so the strategies that we came up with was that clinic leaders would need to recognize and acknowledge that screening is being done and provide reminders to screen patients every time. So you can see kind of at this level, we were a little bit broad with our implementation strategies. And so we did have to I'll talk about in a minute how we got more specific in operationalizing them a little bit later. But in this kind of first round of the matrix, we kept things pretty broad. And then at the national VAC level, where determinants were relative priority of the brief alcohol intervention for sites and alignment of the brief alcohol intervention with national priorities, one of our strategies was having the VAC actually issue a letter to provinces to scale up the brief alcohol intervention, which is something that they would kind of naturally do if there's a new intervention that they want to be implemented. And then we also involved the VAC in conducting regional launching events and trainings with the provincial CDCs and the central team in order to kind of show to the sites that this really was a priority for the VAC and that it was aligned with kind of their national priorities. So finally, in this last step, we use Proctor's framework for implementation strategies, for operationalizing implementation strategies that's cited here, to really specify these strategies further. So this included kind of naming the strategy, defining it, and operationalizing it. And then we were able to develop our standard operating procedures for carrying out our implementation strategies. So here you can see an example of how we further operationalize one of our strategies. So for our strategies of clinic leaders recognizing and acknowledging that screening is being done and providing reminders to screen patients every time, our actors were that clinic leaders were going to be the ones to do this strategy. The action is that they're conducting periodic meetings with clinic staff to report on how many screenings are being done. The target is the site staff. And so the clinic director is going to support screening. Our goal was that by the clinic director supporting screening, this would motivate site staff to screen patients consistently, and also that site staff would understand the importance of the brief alcohol intervention screening and screen every patient. And again, the goal ultimately is to improve implementation fidelity. The dose is ongoing because these periodic meetings are happening throughout implementation. And then when we say timing, meaning kind of like at what phase of the implementation is this happening? Is it at the beginning? Is it throughout? Is it just at the end? And so for this was kind of, the timing was throughout the whole implementation. And so from this work, we actually came up with 23 implementation strategies, which were implemented in both arms, in addition to kind of fully operationalizing our intervention arm strategy, which was the experiential learning strategy. And we had this matrix broken out by all our different actors, kind of the VAC, clinic leaders, and our clinic counselors. And we gave this strategy list to all of our 30 sites, and we then instructed them to modify the strategies to fit their site's context, because we know even though we came up with this strategy in a very collaborative way, 30 sites, within 30 sites, there can be a lot of variation, and we wanted to make sure that these strategies were going to be a good fit. And so an example of this is that some clinic managers ended up not requiring these periodic meetings and instead had clinicians send written reports because they had a really heavy workload and they weren't able to conduct periodic meetings, but they were still able to kind of meet our goals of clinic leaders recognizing and acknowledging that screening is being done just through these written reports instead of meetings. And then each site shared their uploaded implementation plan with our team, and we had periodic calls throughout the study to track changes that were made to the plan, like adding and removing strategies. So for example, one site wanted the central team to provide them with some assistance in creating a counseling checklist. So this is kind of acknowledging that there can be changes that could be made throughout implementation to our strategies, which is kind of the next thing that we're going to talk about now. So this kind of set us up to dive into our the next method I'm going to talk about, which is implementation strategy tracking. And we're going to talk about the strategy within the context of the SNAP study. And here, SNAP stands for Systems Navigation and Psychosocial Counseling. So for the second study that I'm going to talk about today, we were testing two approaches to scaling up systems navigation and psychosocial counseling across 42 HIV testing clinics, so kind of an even larger scale than the eBuy study. And this was for people who inject drugs with a recent HIV diagnosis in Vietnam. And the goal of this trial was to examine if a standard package of 15 implementation strategies that were designed at a central level, which is kind of typically what happens when an intervention is being rolled out, or in an implementation study, you've got kind of, especially in Vietnam, where as I said before, policymaking is top down. You've got the VAC coming up with this list of strategies to support implementation, and then using these strategies kind of and implementing them throughout all of the provinces. And we were comparing that kind of standard package of strategies to a tailored package of implementation strategies, where all sites got the standard package, but they also got additional strategies that were really tailored to address their unique barriers to care. And so one of kind of the perks of implementation mapping and strategy operationalization was that it made it really easy when we wanted to track modifications to strategies over time, because we already had a really clear implementation plan for each site. And why tracking is so important is that it can help to facilitate understanding of outcome results and identifying what really worked and what didn't. So for example, if an implementation strategy didn't work, we want to know, is it because the strategy wasn't effective, or was it because the strategy wasn't being implemented as expected? And we can really only know that through either kind of doing process evaluation or through something like strategy tracking. And this can also be really important for providing guidance in the future for kind of replicating these strategies in other settings, because you really want to know what worked and what didn't. And so in this paper specifically that I'm going to talk about now, we were interested in describing our systematic approach to tracking implementation strategy modifications within the context of this trial and within the context of kind of a low and middle income country setting, and then presenting findings from this tracking process. So how we did this work was that site staff in our tailored arm were asked to track implementation of their strategies monthly and note any changes that were made to their implementation plan. And we also had, our team held 30 to 60 minute monthly meetings within each site to provide coaching to the sites around implementation of new strategies that they were adding and to overcome any barriers that they were experiencing to implementation. And as part of this, they also talked to the clinic staff about any modifications that were made to their strategies over time. And how we did this was through elements of the Frame IS. And the Frame IS, you can see it cited at the bottom of the page, at the bottom of the slides here, is a framework for documenting modifications to implementation strategies. So it's a modified framework from the original Frame, which was for documenting modifications to interventions. And so we use this framework to describe the changes that we made to strategies over the course of the study. And so here you can see on the screen what the frame looks like. So we've got all these different modules, and you go through, and for each strategy, you document what is being modified. Is it the content, the training, context? What's the nature of the modification? Are you tailoring your strategy? Are you substituting it? Are you loosening the structure? There are also some additional optional components. And then you're also documenting what's the goal of the modification and what's the level or rationale for the modification. So it's a really systematic way of being clear about what changes are being made and who's making them and why are they being made. And so through this strategy modification kind of tracking process, our team held a total of 570 online meetings, which is a lot, but it was 42 sites. And so these were 42 sites total, 21 in our TA arm. So these were conducted from July 2020 to March 2023. And again, these were through periodic monthly meetings with site staff. And so here's an example of how our implementation strategies were tracked in 1 month at a SNAP site. So you can see on the screen, one of our strategies was assessing and redesigning workflow. We've listed what barriers does a strategy address and what activities are being done. So for this strategy, the site was developing an action plan on a weekly or monthly basis to inform heads of the department about any plans of assessing and redesigning workflow in order to incorporate the SNAP intervention activities. We listed kind of the dose and the temporality, and then the tracking part came in here. So for this 1 month, was it implemented or not? And then kind of a study of what the implementation looked like. And then in the next row, you can see an example of a strategy that actually wasn't implemented. So one of the strategies the site had come up with was to revise professional roles. And the barrier that they were addressing was that they wanted to overcome any miscommunication that there might be between the counselor and clients who weren't fluent in the national language. And so the activities that were going to be done was to use translators to help communicate about SNAP with study participants who might not be fluent in the popular language. And so at this time point, we saw that this actually wasn't implemented because they hadn't had any participants who needed to use it yet. So this is what the strategy tracking would look like. The staff would call the site and go over their implementation plan, ask them what strategies, going through each strategy, asking if it had been implemented or not, if any revisions had been made, or if it had actually been completed, if it was just like a one-time strategy. And then they would also talk through any barriers they might be experiencing to implementation. So now I'm going to get into some of the actual results of what the strategy tracking actually looked like, and kind of how the strategies were used across the study. So here you can see on this graph the percentage of the 21 sites using each of the 9 ERIC categories. So the ERIC strategies are categorized into these 9 different categories that you can see kind of in all capitals. So like use and evaluative and iterative strategies, develop stakeholder interrelationships, train and educate stakeholders. And then the different strategies organized by the ERIC categories are on the y-axis. So you can see below the broader categories are the specific implementation strategies. And then the percentage of the 21 sites using each strategy are actually on the x-axis. So for example, the number of implementation strategies. For example, you can see that like provide interactive assistance was used by 57, a little more than half of the sites, of those 21 sites. And so what we found overall was that the number of implementation strategies identified by the 21 sites was 27 discrete strategies, and at least one strategy in all of the ERIC categories and all the ERIC taxonomy categories was used, except for the category of adapt and tailor to context. And we also saw that assess and redesign workflow and alter incentives were two new strategies that were added that weren't originally part of the ERIC taxonomy. So those were also documented here. So in this graph, you can see that there was actually a lot of variability in the number and the types of strategies chosen across the 21 sites. So on the y-axis, you can see each of the 21 sites from 1 to 21. And then on the x-axis, the number of strategies used by a site are listed, and you can see that, and they're listed by the 9 CFR categories. So for example, you can see that site 5 was a site that used the most strategies, and they used 14 strategies total, including 4 different strategies within the developed stakeholder interrelationships category, which you can see is kind of in yellow on the slide there. And we also saw that the category of developed stakeholder interrelationships was the one that was used by the most sites, because you can see kind of all of those sites have kind of a yellow bar there. And it was the only category that was selected by all sites. And finally, just ending on this graph. This is a graph that kind of shows the number of strategies that were used actually across the whole study period. And so you can see the average number of strategies that were used in the TA sites over the course of the study. So you can see that study month is on the x-axis, starting with our planning phase and going all the way to March 2023. And you can see that the average number of strategies used across the 21 sites is on the y-axis there. So in the planning phase, the mean number of strategies identified per site was 7, while in that last month, you can see it went all the way down to just 1. And this isn't totally unexpected. There were a number of factors that contributed to the reduction of strategies over time. And kind of one of the main things was that some strategies only needed to be implemented once throughout the study. So something like kind of conducting early stakeholder meetings might have just needed to be conducted once and then could be discontinued. Or another thing that happened was that some site staff decided that a strategy didn't actually need to be used anymore, and so they stopped doing it. Another thing that came up was that some sites just simply were really busy with other tasks. The SNAP study was happening during the middle of the COVID-19 pandemic, and so some of these sites were getting called away to do rapid response activities, and they could not keep up with all the implementation strategies. So that was another reason for the drop over time. And we also saw that over the course of the study, 2 new strategies were added to 12 of the sites, and modifications of 5 of our strategies occurred at 4 sites to accommodate kind of their changing needs and resources. So what do all these graphs, what does this all mean? I think the big takeaway is that we identified that even though it was pretty intensive, you saw that there were 570 calls that were made. So this is a pretty intensive activity. It was possible even in a low to middle income country setting like Vietnam, so that we saw that this kind of strategy activity work is feasible. And this also really reaffirmed that implementation strategies are really dynamic over the course of a trial, over lots of different sites, and kind of reaffirmed that it's really important to be tracking what's going on, because if we hadn't been doing this work, we wouldn't have known that strategies were being added, strategies were being removed, they were decreasing over time. And so this is why we think this work is really important to do. Okay, so I'm gonna end now talking about a third method that we used in both the SNAP and the eBuy studies, which was sustainment strategy development. So I'm going to switch gears a little bit to talk about some of the work that we did around partnered optimization of sustainment strategies. So I've been talking about implementation strategies up until now, and I'm going to switch gears a little bit to talk about sustainment strategies. And our work with sustainment strategies really emerged out of the SNAP study, that last study I talked about around systems navigation and psychosocial counseling. And this work came out of a piece of my dissertation research that sought to examine, through interviews with participating clinic staff and leadership, what happened to the SNAP intervention after the kind of formal SNAP study ended. We were interested in seeing, okay, this isn't too intensive of an intervention. It's 2 systems navigation and 1 psychosocial counseling session. And we know that this is a big priority. We've given the clinics all the tools that they need to do this with people who inject drugs. Are they actually able to sustain it after kind of study support is removed? And again, that study support was pretty minimal because it was an implementation science study. And so what we learned was that out of a purposefully selected sample of 12 clinics, we found that at 6 to 10 months, so really not that much longer after the study ended, only 1 clinic had continued to sustain all of SNAP's core components, while 75% of clinics sustained only part of SNAP and made kind of big adaptations, like cutting down the time that the sessions were taking place, or removing one of the systems navigation sessions, so making pretty big changes to the intervention. And we were also really interested in factors that led to SNAP being sustained and or adapted. And the things that we found was that maybe not super surprisingly, things that were really important for sustainment were leadership direction and support around implementation, external mandates from places like VAC or from provincial centers for disease control around systems navigation activities, how perceptions around how effective and valuable the intervention was, continued training for sites and training continuity if there was turnover in roles, as well as technical support and knowledge sharing. And then a big one was just how enthusiastic and motivated the staff was to continue doing these systems navigation activities, and how big of an issue they saw that injection drug use was among their population. And so we, seeing that sustainment was a major challenge, and that it was really kind of unevenly implemented across the 42 clinics after SNAP ended, we took ideas from the SNAP study and we used them to develop sustainment strategies for EBI, the experiential brief alcohol intervention that I talked about at the beginning. And so we developed these strategies. Based on kind of those interviews that we did with clinic staff around what they thought would be important to sustain the SNAP intervention and kind of HIV interventions more broadly. And so we came up with 15 different sustainment strategies. These were things like providing training recordings, providing ongoing study data on the effectiveness of the intervention, having the VAC ask for regular reports from the staff on how they were doing with continued implementation, doing kind of planning for adaptation, having the VAC actually deliver the experiential brief alcohol intervention instead of the study staff. So 15 different strategies that we thought would be important and for the experiential brief alcohol intervention to be sustained after the formal implementation trial ended. So 15 is a lot of strategies. So in order to narrow these strategies down to those that were going to be both most important and feasible to the sites, we decided to conduct a strategies prioritization activity with our collaborators. So we first interviewed and surveyed 12 collaborators. So this included 3 members from the VAC, 3 CDC and Department of Health leaders, 3 clinic directors, and 3 clinic staff. And we surveyed them on these 15 different sustainment strategies using a 4-point Likert scale to ask them how similar are these strategies to things that you would normally do to keep conducting projects long term, because we kind of hypothesized that if the strategy is more similar to what they're normally doing, that they would be more likely to do in the long term. How useful did they perceive the strategy for encouraging BAI sustainment, and then how feasible was the strategy for encouraging sustainment? And then we also conducted brief qualitative interviews to help explain any responses to the survey and to help identify any potential sustainment strategies that we missed. And so here you can see some of the results from this sustainment strategy prioritization activity. In the columns, you can see the different actors who we talked to. So V is VAC, C is CDC, D is clinic directors, and S is clinic staff. And then we've got the different strategies in the rows. And these scores that you can see here are average across those three domains. So again, similarity, utility, and feasibility. And then we have our lowest scores highlighted in red and our highest scores highlighted in yellow. And so overall, what we found was that across participant groups, the strategies of researchers showing clinics how effective the intervention was to motivate them to keep implementing the intervention, providing staff with training materials, and integration of the brief alcohol intervention with current HIV trainings, as well as having kind of a focal point who is going to be responsible for the brief alcohol intervention after the trial ended, where these are the strategies that were both most perceived as most feasible and most important for sustainment of the brief alcohol intervention. And another interesting thing that we saw was that strategies that tended to be most onerous for a specific group tended to be the ones that were rated lowest by that group, which I think makes a lot of sense. So for example, the strategy of the VAC staff delivering the experiential brief alcohol intervention was rated pretty low by the VAC, and they were the ones who were going to have to deliver that strategy, whereas it was rated higher by other actors. And so after doing this strategy prioritization activity and narrowing down our strategies to the ones that were going to be both most feasible, important, and similar to things that they were already doing, we provided clinics with toolkits of these strategies to use as the trial ended at their site to support sustainment of the brief alcohol intervention long term. And then we're going to go back a year later and see if they've actually continued to implement the intervention as well as any of these strategies. And I think in the future, ideally, we would be kind of doing this in a more experimental way. But for now, we're just kind of seeing what happens with these strategies over time and how that might impact continued implementation of the brief alcohol intervention after the trial ends. So having gone through these three different methods, I'm going to talk very briefly about some of my current work around strategy optimization and then give some key takeaways. So I'm not going to talk too much about the work that I'm doing at the VA today, but I'm happy to talk about it more with anyone who's interested in it. But some of the work I'm currently doing is how to optimize clinical champion strategies. And specifically, I'm working on developing a model of how to prepare and train clinical champions within large healthcare systems like the VA, given that this is a major gap in the literature. And we know that in small trials, you might be able to kind of hand pick your clinical champions, but in large settings like the VA, you have people coming in with very different skill sets, very different levels of knowledge, and there's not a lot out there about how to best train them to be kind of at the same level of readiness to be effective clinical champions. And we think that that's kind of one of the reasons why clinical champions is an implementation strategy. The effectiveness of that strategy is a bit mixed. And then another area in terms of implementation and sustainment strategy optimization that I'm working on is that I'm currently developing a model for partnered implementation playbook development. And I'm happy to talk about either of these at another time. So providing just some key takeaways, we think that powerful and contextually appropriate implementation strategies are really needed to close that research to practice gap that I talked about at the beginning of the presentation. And today I presented three different methods that are really great ways to optimize strategies, doing things like implementation mapping, implementation strategy tracking, and partner-driven sustainment strategy prioritization can really support strengthening strategies and can improve their relevance to the sites that are going to be using them. And finally, use of more systematic processes during implementation research and practice can really support understanding of implementation mechanisms. So understanding how do these strategies work, including kind of whether, when, and how a strategy is going to work in a given setting, which is really important for optimizing our strategies and for overall advancing the implementation science field. So that's everything I have today, and I'm happy to take any questions at this time.
Thank you so much, Dr. Bartels. That was such a great talk and so great to hear about all of the different efforts around implementation strategies and assessing and measuring them. We have a couple questions we can get started with.
Mhm.
One comment and question. I know it's challenging to know which of the strategies you used were the secret sauce, but given
Mhm.
that developing stakeholder relationships was so widely used, is it possible to conclude that this strategy is a must to include in similar or future efforts?
Yeah, I definitely agree that kind of one of the challenges with having so many strategies is knowing kind of what is the one that's really most effective. But I do think that when we're doing implementation science, particularly in doing global implementation science, I do think probably we can conclude that developing stakeholder relationships is going to have to happen in both our control and intervention arm in order to have an implementation effort be effective. So I think that's a fair thing to conclude.
Yeah, I think that makes a lot of sense regardless of your context.
Mm-hmm.
Okay. Another question is about the Frame IS. How was the Frame IS administered? Is it a self-administered electronic tool, or does a grantee or research assistant collect data in real time via phone or conference call? How is it analyzed after data is collected and kind of managed?
Yeah, that's a great question, and I think one of the one of the things we're still working on is kind of the best way and the most optimal way to track implementation strategies. So what we did was that we were originally hoping in our trials that once we gave sites implementation plans that they would be going through as they were making changes to their strategies and kind of noting those changes because we were concerned that if we're just calling them once a month, they might be forgetting the details of what they're doing and why they're doing it. As you might expect, the study staff are very busy and didn't really mark down modifications as they were happening. And so how it worked for us was that we had during those monthly study calls, we had the study staff ask them about in the past month what modifications were made, what changes were added or removed. And then our staff then went through and noted kind of as part of these interviews, like why the changes were made and kind of filled out the frame IS that way on kind of the back end. And so I think it is a potential limitation that that this is a pretty intensive thing to do, and you wouldn't necessarily expect busy clinicians to be able to be monitoring and reporting the modifications that are going on to strategies. So I think it is kind of necessary to have someone who's designated and has designated study time to be able to do this work. And I think we had originally hoped that we gave some like a little bit of primer and implementation strategies to the site staff, but as they were going through and marking changes to the implementation strategies, we then had to go back and kind of categorize them based on the ERIC taxonomy in order to standardize them across the sites because they weren't thinking in necessarily in implementation science or in these very specific categories when they were marking changes that were being made or strategies that they were adding. They just said that, oh, this is what we did. And so there was some kind of back end coding that our team had to do in order to kind of standardize and see what strategies were being done across our sites. So it was definitely a little bit more complicated of a thing to do and something that we're still working on to figure out the best way to do the strategy tracking work.
Right, right. Yeah, and from a practical point of view, what after you're getting all this data on the implementation strategy, adaptations and modifications
Mm-hmm.
in a real world practice setting, do you then just recommend that they stay and continue the adapted or modified kind of version of the original strategy? Or, I mean, would this need to be done, um, a new process in different clinics, or would you kind of use this as a model for, okay, maybe this is a more feasible or kind of like acceptable or relevant, like kind of appropriate way to implement that strategy within our kind of our setting?
Yeah, I think probably the latter. It definitely gets a little bit tricky at that point, thinking about how do we maintain fidelity to our core components versus how are we making sure that that the intervention is a really good fit for our study context. And obviously, we had the intervention was originally developed in the U.S., and then there were modifications that were made for both the eBuy study and for the SNAP study. There was an intensive adaptation process, and then they were evaluated. And then, but it just, yeah, I think it's really important to be thinking about how can we make sure that these strategies and the intervention themselves are kind of straddling that line between still we have the core components that are going to be effective while they're going to still be a good fit to our context. So I think it is a little bit of a challenge to walk that line, but I think it is a great opportunity for learning. Okay, maybe when we're implementing this intervention across all these different clinics with all these different types of resources, maybe we do need to think a little bit more about, is this still really a core component, or can it, in this context, can there be more changes to be made? So I think it is a little bit of walking that line.
Yeah, yeah, and it's great that you have that input from, your stakeholders to try to figure out what's really going to work. Okay, and another question that we have is, I'm curious to hear a bit more about how you are approaching training champions. I agree that this is so important, but it can be tricky. What general approaches are you taking, or can you describe this a bit more?
Yeah, happy to talk a little bit about this. So this clinical champion training effort is being undertaken across the whole VA for whole health. And so whole health is the VA's model of care that's really focused on what matters most to the patient. And it's a big initiative, as I said, across all VA. And as part of that work, clinical champions are being implemented within primary care and mental health clinics, primary care and mental health settings, to help facilitate whole health, kind of this transition to whole health and integration into all the work that's being done in the VA. And so they have a big, each kind of round of clinical champions has a training effort that's led by the Office of Patient-Centered Care and Cultural Transformation in the VA. And what we were finding was that there wasn't maybe quite enough of tailoring to where each champion was, both in terms of how comfortable they were with the whole health intervention itself, and how comfortable they were, how knowledgeable they were, what their skill set was in terms of the clinical champion activities, because those two things are very different, and you have to have both of those in order to have an effective clinical champion. And so there had been a lot of focus on training around whole health, and a little bit less training around how to be a really effective clinical champion. There have definitely been some, but there was more work to be done. And so there have kind of been multiple rounds of feedback, both with our research team helping to evaluate this implementation effort, and then the Office of Patient-Centered Care and Cultural Transformation incorporating some of the evaluation work that we're doing into the training. And so there's a lot of kind of iterative cycles, but that's just a little bit about that specific clinical champion initiative. And we're hoping a paper is going to come out soon about that model of training clinical champions that's focused both on those two levels of training related to the intervention and the clinical champion work itself. And that's all grounded within the ADCAR, which is a change management framework.
That's really exciting. I think we all need more champions to help help increase the adoption of some of these evidence-based practices.
Mhm.
I'm wondering, do you think that model would translate to other settings, like more community-based practice settings or even school settings, or how do you think it would apply to other settings outside of the VA?
Yeah, I think it's definitely translatable. I mean, I think it would have to obviously be tested to see if it's kind of the premises we built this conceptual model that we came up with based on a lot of interviews and survey kind of iterative rounds with these clinical champions, and so we would want to make sure that the kind of the assumptions that it's based on still hold. But I think the premise and the kind of the use of the ADCAR, which really is translatable across settings, I think it definitely could be, and I would hope it would be.
Great. Well, we don't have any other questions coming up in the chat. So I might just give people back a couple more minutes of their time today. And this was our last seminar in the fall seminar series here that the Bridge program hosts at Brown University. And Dr. Bartels, thank you so much again for helping us close out our fall seminar series with this amazing talk. And we thank everybody who has tuned in today for the talk, and we hope you will all join us again next year in the fall. Thanks, everyone. Take care.